So today we are going to do a new chapter of pharmacology, and this chapter is glaucoma. So today we are discussing about the glaucoma, which is the retinal damage, okay, due to your increased intraocular blood pressure. So we'll understand what is glaucoma. We'll understand the basic framework, how glaucoma is being caused, what are the different drugs we have for glaucoma, how can we manage glaucoma, and a variety of drugs, and we'll see about the types of glaucoma, okay? About the primary open angle glaucoma or your angle closure glaucoma, and how they are caused. Prerequisite is that you must have a basic understanding of your anticholinergic drugs as well as your receptors, your M1, M2, M3 receptors. You should have a basic understanding. Otherwise, I'll make sure that you understand that easily. We'll discuss about like what are the side effects of anti-glaucomic drugs. Okay. We'll discuss about something called as heterochromia iridis or cystoid macular edema. We'll discuss about that and about what beta blockers we use to treat glaucoma. We'll see about that. We'll see about the adverse effects, about what meiotic agents we use, what are the alpha agonists we use. Okay, we'll discuss about a variety of things today. So, starting with so what is glaucoma? So, glaucoma is the retinal damage. It's the damage of your optic nerve due to an increase in pressure. If the aqueous humor is not being drained out, there is increased aqueous humor production. Either there may be decreased outflow or increased secretion. So, due to decreased outflow, increased secretion, whatever may be the cause, will there will be occurrence of your glaucoma. Okay. So, let's write what is the definition. The definition is the uh, retinal damage. You can just simply write retinal damage. Retinal damage, and this retinal damage is due to increased IOP, that is intraocular pressure, due to increased IOP. And this increased IOP in turn is due to increased aqueous humor, increased aqueous humor, okay, due to increased aqueous humor. And the drugs which are for glaucoma, we call them as ocular hypotensive drugs. That is, hypotensive means reduction. So the drugs reduce the intraocular pressure. Okay. With this, let's draw a schematic diagram to understand how the aqueous humor is being produced and what is the defect, which part is defective in case of your glaucoma. So, if you can imagine the eye, let's draw like this. You have the cornea here. Okay? You have the cornea like this. Let's make it big. It's a super schematic picture that is not the real one of eye. This picture will help us to understand what is the mechanism of glaucoma. Here we have the iris. I'm writing I in place of iris. Okay. And then we'll draw it something like this. Just ignore the background noises. Maybe there are some noises around there. No problem. Here we'll have our lens and some ciliary muscles that will be holding to it. And here we have the ciliary epithelium. This is the ciliary epithelium. So here, let's not use the pencil much. Here you have the ciliary epithelium. And on outside you have the ciliary blood vessels. So you have the ciliary epithelium, the ciliary blood vessels, and the ciliary blood vessels will have the presence of alpha 1 receptors. The alpha 1 receptors are present upon this ciliary epithelium. And this alpha 1 receptors, if you have known, is causing vasoconstriction. Vasoconstriction means your blood vessels are compressed. So this alpha 1 receptors are basically causing your vasoconstriction, and due to this vasoconstriction, this is decreasing the production of aqueous humor. Decrease production. So if these are decreasing the production of aqueous humor, basically they are helping us. They are helping us so as to not produce glaucoma. They are helping us so as to not produce glaucoma. So if we'll give alpha 1 agonist drugs, will that help in glaucoma? Yes. So alpha 1 agonists are useful in glaucoma. Very easy. Let's talk about some other things. So here we have a trabecular meshwork, TM. I'm writing TM, and this TM is trabecular meshwork. This is helpful in draining of your aqueous humor. The aqueous humor, when it is produced by the ciliary epithelium. This aqueous humor is drained in two routes. One is the trabecular network, and then we have something called as a eviosacral outflow. You must have known about uvea. Okay, I said sacral. Pardon me, uveoscleral. Okay, not sacral. This is the sclera. This must be the white of the eye, right? This is the sclera. So uvea and sclera. So you must have known about the uveoscleral outflow. So 90% goes via the. Let's discuss the production. So if this produces the aqueous humor, I am writing AQH. This aqueous humor must be being drained into the trabecular meshwork as well as a uveoscleral outflow. So 90% gets about 90% gets drained by this, and somewhere 10% around via the uveoscleral outflow. Understood? And we'll see the receptors that are present here. So let's discuss about the receptors as well. Okay. So here in the uveoscleral outflow region, we have something called as the alpha 2 receptors. Here we have some alpha 2 receptors. In the ciliary blood vessels, we had alpha 1, and here we have the alpha 2 receptors, as well as the PGF, prostaglandin growth factor 2 alpha receptors, PGF2 receptors. Just you can remember alpha 2 receptors are present here, and these receptors are increasing the outflow. They are increasing the outflow. They are helping us, yes. So these receptors are helping us, in fact, in glaucoma. So they are also helpful in managing the glaucoma rather than increasing the incidence of glaucoma. So we'll give alpha 2 agonists drug as well. We'll give alpha 2 agonist drug as well. Here, another type of receptor we'll see. Let's mark the receptors. This I am marking 1, that is the alpha 1 receptor. Here I am marking 2, that is the alpha 2 receptor. And on the ciliary epithelium also, we have the presence of receptors like this. And this on the ciliary epithelium, will have alpha 2 receptor, beta 2 receptor, as well as your uh, carbonic anhydrase receptors. Okay? Carbonic anhydrase receptors. So these three, alpha 2, beta 2, as well as your carbonic anhydrase receptor. And these three receptors are present on your ciliary epithelium. on your ciliary epithelium. So if you could understand this concept, let's discuss about the roles. So alpha 2 receptor, what is the role of alpha 2 receptor? This decrease the secretion of aqueous humor. Decrease. So basically alpha 2 are helping us to manage the glaucoma. Our main goal is to treat the patient, not to know concepts. Our main goal is to treat the patient. So of course we will give the alpha 2 agonist or your alpha 1 agonist so as to treat the glaucoma. Let's talk about beta 2. What is the role of beta 2? Beta 2 is increasing the aqueous secretion. So these are not helping us. So we have to give a beta blocker. These are bad. So we will give a beta blocker so as to treat the glaucoma. And the carbonic anhydrase receptors also work in the same way as beta 2. So we'll also give a carbonic anhydrase inhibitor drug so as to treat glaucoma. So if you could understand this whole concept of aqueous humor production, its drainage, the receptors, the work of receptors, then what drugs must be there for glaucoma? So we have something called as a alpha agonists. Of course, you can understand why we are giving the alpha agonists. We have something called as a beta blockers and carbonic anhydrase blockers. So these three drugs are the drugs approved for glaucoma. So if you could understand these drugs which are approved for glaucoma, they're approved for glaucoma, we'll see what are the two types of glaucoma as well, and what other drug can be given in case of glaucoma. So let's discuss about the types of glaucoma now. Types. So the first type is the glaucoma in which there is increase in the pore size of your trabecular meshwork. In which there is increase in pore size of your trabecular meshwork. So first one is the primary open angle glaucoma. I'm writing OAG for open angle glaucoma. Okay. The primary open angle glaucoma in this, due to old age, due to any old age related degenerative changes, there is increase in pore size of trabecular. Sorry, there is reduction because there is glaucoma. Okay, so there must be reduction in pore size. Sorry, if we'll increase the pore size, then what will happen that more will be drained, so there will be no glaucoma at all. So we have to reduce the pore size as well as to decrease the outflow. So there is reduction in pore size of your trabecular meshwork. That is called as the primary open angle glaucoma. And we have something called as the angle closure glaucoma. So second one is the angle closure glaucoma, writing ACG. In this angle closure glaucoma, if a person is there with increased pupil size, let's say the person is there with increased pupil size, okay, uh, or if there is mydriasis, you know what is mydriasis, okay. So if there is mydriasis or there is increased pupil size, this distance in which the iris was present, this is not this is now like this normally. But if there is mydriasis or increased pupil size, there will be stretching of this. And due to the stretching, here where trabecular meshwork was present, the spores will be closed. The spores will be closed. And due to this closing, let me draw a basic framework so as to make you understand. So we drew something like this. Here, here we drew the trabecular meshwork, the cornea, here the iris, the retina, and the lens. This is the basic structure. So here I am telling that if there is increased pupil size, this whole part will be like this, something like this. This whole part will spread out. If this whole part spread out, there will be reduction or disappearance in trabecular meswork. And if there is disappearance in trabecular meswork, there will be no drainage of the aqueous humor. And if there is no drainage of the aqueous humor, will suffer from glaucoma. So, what can you do? What can you do to prevent this? You can give, if there is mydriasis, this will occur. So you will give the meiotic agents. You will give some meiotic agents, which will open up this IC angle. What is IC angle? I told about IC angle. So what is IC angle? This is iridio-corneal angle, IC angle. So as to open up IC angle. To open up the IC angle or the iridio-corneal angle will give the meiotic agents. Will give the meiotic agents. Okay. So if you could understand this concept, let's discuss about one more thing. You must, I said that anticholinergic drugs and ANS is a requisite. Like if you have studied ANS, then it's very easy. Otherwise, I'm telling like you gave atropine, or you gave some tricyclic antidepressant. Let's assume you gave atropine or some tricyclic antidepressants, or you gave atropine like drugs or some tricyclic antidepressants, then this have anticholinergic action. You know that if this have anticholinergic action, these drugs will block which receptor? M3 receptor. These drugs will block M3 receptor. This M3 receptor, if they block the M3 receptors, if they block the M3 receptors, then what will occur? They will close the IC angle as well. They will also close IC angle as well. If they close IC angle, then there will be mydriasis. And if there will be mydriasis, then the same concept, angle closure glaucoma. So this anticholinergic drugs, I'm writing ACD, this anticholinergic drugs also can cause your angle closure glaucoma. So be cautious when you are prescribing the anticholinergic drugs. Okay. Okay. So let's talk about the drug of choice. So the main important thing here, the drug of choice. So what is the drug of choice for both the types of your glaucoma? So for both glaucoma, you have to use prostaglandin F2 alpha agonists. Okay, prostaglandin F2 alpha agonists. And prostaglandin F2 alpha agonists, these are if this works well and fine. If this doesn't work, we'll combine it with other drugs as well. So this prostaglandin F2 alpha agonists are given as basically eye drops. Okay, these are basically given as your eye drops. Eye drops. So we'll give the prostaglandin F2 alpha agonists as eye drops. After that, you want to know if about the mechanism. If you want to know about the mechanism, simple. Look at this. We had prostaglandin F2 alpha receptors upon your uveoscleral outflow. So if you give the agonist, this will increase the uveoscleral outflow of aqueous humor. If this increases the uveoscleral outflow of aqueous humor, there will be increased drainage of aqueous humor. And if there is increased drainage of aqueous humor, then of course we will be treating with glaucoma. The glaucoma will be treated. Yes. So what are the drugs which are there? So in F2 alpha agonists, just remember the drugs end with prost. Prost. The drugs end with Prost. I'm writing two drugs. Just remember this two. We have many, like 4 or 5 drugs. Uh, Important ones are your latanoprost, your latanoprost, or your bimatoprost. These are basically two I'm writing. We have some traboprost, okay, and tafluprost. Many drugs are there. Just you can remember latanoprost and bimatoprost. And what are the adverse effects of if you give the prostaglandin F2 alpha agonists? That you know that prostaglandin increases inflammation, and if you give this prostaglandin F2 alpha agonists, there may be three very classical side effects. So we have some side effects of this prostaglandin F2 alpha agonist. We have something called as a heterochromia iridis. Heterochromia iridis. Heterochromia iridis is the difference in the eyeball color, difference in the color of the eyeball. Okay? So this heterochromia iridis. And we have something called is uh, like cystoid macular edema. Cystoid macular edema. So here what happens, the retinal blood vessels, they are basically, there is inflammation. So prostaglandin, they're causing the inflammation. So there is inflammation of retinal blood vessels. Due to this, edema will be caused. You know, where there is inflammation, there will be edema as well. So here we have the edema. You will see in fundoscopy, if you just take out a fundoscopy of the eye, then the cystoid macular edema will be looking like yellowish circle. We'll leave to the ophthalmologist to talk about that. Okay. And another side effect, another very classical side effect is your hypertrichosis. Your hypertrichosis. So this hypertrichosis also, that is increased hair growth. Hypertrichosis is increased hair growth, increase in eyelashes, or increase in eyeball, increase in hair. This all. This hypertrichosis, heterochromia iridis, and your cystoid macular edema. These three are the very classical side effects if you give your prostaglandin F2 alpha agonist. Yeah, you know about the causes as well. Cystoid macular edema, I told, that is edema of your macular blood vessels, retinal blood vessels. Heterochromia iridis, the cause is simple. Like if there is inflammation, there will be decreased melanin. If there is inflammation, the cells will not use up melanin, so the melanin decreases. And due to this decrease in melanin, the eyeball generally becomes your grayish in color due to decrease in melanin. Well, you can just Google up the heterochromia iridis. Very beautiful images will pop up. And cystoid macular edema, you can just well appreciate a fundoscopy if you can Google it up. And hypertrichosis, you must have seen patients, or I don't know if you have. Okay, understood. So these are your F2 alpha agonists. What to remember? Your latanoprost, then your bimatoprost, latanoprost, bimatoprost in F2 alpha agonist. If you want to just write, you can write triboprost, okay, or tafluprost. Okay, so these are your drugs in F2 alpha agonists. Let's discuss about our second type of drug, that is your beta blockers. So let's talk about today about the beta blockers. What is the mechanism of action? Beta blockers, we saw here, beta blockers will block the action of B2, block the action of B2 receptor. And if this block the action of B2 receptor, the the ciliary blood vessels, there will be a decreased production of aqueous humor. They will decrease the production of aqueous humor. So here we have the beta blockers, which will reduce the aqueous secretion from your ciliary epithelium. You can have the topical eye drops. Sorry, there was a call. If we were in beta blockers, so this beta blocker I told, they will block the beta 2 receptors, and this will reduce the aqueous secretion from a ciliary epithelium. So we have non-selective beta blockers, or you can have selective beta blockers. Okay, you can have a non-selective beta blockers. What it do is basically they will block beta 1 as well as beta 2, and the selective beta blocker will specifically block a beta 1. They block more beta 1 than beta 2. Okay. Uh, we'll discuss about both of them, and we'll discuss about some adverse effects of these beta blockers as well. You must have read beta blockers in very detail if you have studied the ANS. Okay. But let me just teach you about the beta blockers. So we have your selective as well as non-selective beta blockers. Selective beta blockers, and we have non-selective. Non-selective beta blockers. So if you are discussing about selective and non-selective, you can just remember this selective beta blockers are often called as the cardio-selective beta blockers as well. Okay, these are also called as cardio-selective beta blockers. Okay, the main example, in cardio-selective beta blocker is a bitaxolol. 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 Okay. We have made a levo form as well. We make some levo forms as well. Okay. Like methyl dopa. We made alpha methyl dopa, L dopa, carbidopa. Okay. Like that we tend to make the optical isomers of the drug. So we have bitaxolol, as well as we have something called as a levobitaxolol. Don't need to go much detail in this, but yeah, a special point about levobitaxolol, it is very safe in asthma. It is safe in asthma. If a patient comes to you with glaucoma as well as asthma, will tend to use to treat the glaucoma, will tend to use your levobitaxolol. Okay, just remember that this beta blockers can provoke asthma. These beta blockers, what they tend to do is beta blockers are basically absorbed through the nasolacrimal duct. They will, if you put an eye drop, they will go to the punctum. From the punctum, they will tend to be absorbed from the nasolacrimal duct. And if they were absorbed from the nasolacrimal duct, then they can go to the nose. If they go to the nose, they can be absorbed into the blood. And if they are absorbed into the blood, they can provoke asthma. So bitaxolol or levobitaxolol is very, very safe. The most preferred one is the most preferred beta blocker in asthma. Most preferred beta blocker in asthma. Okay. And if we are talking about non-selective, we have all the lols are there. So until 12th, we knew that lol is just laugh out loud. But in pharmacology, if we are talking about lol, they are beta blocker. Okay. We have something called the timolol. Something called the timolol. Or we can have cartelol. Okay, can have cartiolol, timolol, cartiolol, and levobunol. Levobunolol, maybe it's. I hope spelling is correct. Okay, So these non-selective beta blockers. In case of glaucoma, these are more effective. These are more effective than the selective cardioselective glaucoma. Okay, and just remember that this levobunolol, levobunolol, the very specific special point as per the levobunolol is considered is the longest topical beta blocker. Longest topical beta blocker. Okay. And if we are talking about the adverse effects, we talked about beta blockers, selective, non-selective. Let's discuss about the adverse effects of beta blockers. Adverse effects. So if we're discussing about adverse effects, we have something very specific. It's called the, uh, let's write it with any good color. Let's take orange. Allergic blepharoconjunctivitis. Allergic blepharoconjunctivitis. So in this allergic blepharoconjunctivitis, which is seen in almost every anti-glaucomic drugs, and most you will read that it is most commonly seen or maximally seen in apraclonidine. In timolol, yes, it's present, but in apraclonidine, it's a very dangerous thing. Okay, not much like it's type of allergy only. You can just understand that it's a type of allergy only. And we'll see blepharospasm as well. Blepharospasm as the allergic blepharoconjunctivitis, blepharospasm. This two you can just remember. These two you can just remember the adverse effects of a beta blocker eye drops. Okay. Next we'll use meiotic drugs. Next we'll talk about some meiotic drugs. Meiotics. Let's talk about the meiotics. So in meiotics, what is the use of meiotics? We understood that there is mydriasis in your glaucoma. So if you give meiotics, the meiotics will open up the iridocorneal angle. And if they open up the iridocorneal angle, there will be increased trabecular outflow, as this trabecular meshwork will be increased in size. Okay, they were compressed in mydriasis. We discussed earlier here. Look at this. These were compressed in mydriasis. They will be opened up. Okay, so we discussed what is the use like effect of your meiotics. We'll first see what are the eye drops which are there in your meiotics. So we have some eye drops like pilocarpine, the most important. Just don't forget pilocarpine eye drops. Pilocarpine eye drops. Sorry, my camera is a bit unsteady. I guess. Yeah, it's fine. Hmm. Pilocarpine eye drops. So pilocarpine eye drops, they are very directly acting M3 agonists. What I mean to say is they directly stimulate the M3. And if they stimulate the M3, there will be increased trabecular outflow as mydriasis is inhibited and there will be meiosis. And if there is meiosis, of course, you will be protected from your glaucoma. Okay, so these are directly stimulating the M3 receptors. But pilocarpine, it can cause increased lacrimation. So if you give a patient pilocarpine, there may be a side effect of epiphora. What is epiphora? Epiphora is baseless crying. Okay, so pilocarpine, of course, it is good to use. It is preferred. Okay, but you can just remember that this will cause your a specific side effect, which is called as epiphora. That is crying, epiphora or crying. Okay, and this pilocarpine, This is present as eye drops. So you can prescribe pilocarpine eye drops. In pilocarpine eye drops, you can have a 0.5 to 4% pilocarpine eye drops. Pilocarpine. We have recently an implant. We have recently an implant made up of your pilocarpine. Like we have this type of reservoirs. This type of reservoirs where pilocarpine is there. This is a pilocarpine membrane or your pilocarpine reservoir. So this type of implant is inserted into the eye. So this is called occlusert. So you can have either eye drops or you can have some eye implants, that is occlusert. Okay, understood. Then we have something called the pilocarpine is there, and then we have another one. Okay, another thing to note that pilocarpine eye drops, they cause ciliary muscle spasm. They cause, let's write it pink, can cause ciliary muscle spasm, and if they cause your ciliary muscle spasm, it will cause pain. Okay, so pilocarpine eye drops are really really painful. They're painful. They're painful. Understood. Next we have a carbamate drug. If you have studied in ANS, it's very easy. They have a carbamate drug, that is physostigmine. Physostigmine. Physostigmine, have you studied? Neostigmine, physostigmine will increase the ACH level. So physostigmine is your cholinergic drug. It will increase your ACH level. If it increases the ACH level, it will directly stimulate your M3 receptor, and this M3 will do the same. It will cause your meiosis. And the third drug you can remember, that is ecothiopate. Ecothiopate, okay, which is an organophosphate drug. If you have studied carbamate and organophosphorus poisoning in ANS, it is very easy. It will also increase the ACH and will stimulate the M3. Stimulate the M3. So in adverse effects, we talked about this meiotics, but the adverse effects, here from here that epiphora will be caused. Here epiphora will be caused. That will be the running eyes or crying. Okay, and there will be ciliary muscle spasm also. The ciliary muscle spasm as well as this, and this ecothiopate can also cause cataract as well. So this is also a side effect. Understood? Afterwards, we'll talk about some alpha agonists. Okay, we'll talk about some alpha agonists, and then we'll talk about some carbonic anhydrase inhibitors as well, which will be useful in this controlling of glaucoma, and then we ending up glaucoma. But for today, we'll be doing this much only, because I hope this much is enough for your university as well as NEET-PG or your USMLE exams. I hope you understood the basic concept behind glaucoma. We discussed various categories of drugs that see. We talked about your prostaglandin F2 alpha agonist drugs today. We talked about beta blockers as well. We talked about meiotic agents. If I just give you an overview, your F2 alpha agonist, these are your drug of choice, and your latanoprost, bimatoprost, okay, tafluprost, and your travoprost. These are your drugs. In beta blockers, we have selective beta blocker, that is a bitaxolol or a levobitaxolol. Non-selective, we have timolol, cartelol, and levuvinolol. Then in meiotic agents, we have pilocarpine and physostigmine. Pilocarpine, physostigmine, and ecothiopate, if you want to remember. So that much in today's lecture. This is the part 1 lecture of glaucoma. We'll continue in next class. We'll continue this lecture in the next class in the glaucoma part 2. I hope you are enjoying pharmacology. Pharmacology is very interesting if it is read very conceptually. So let's end up here, because it's already lunchtime. I thought that I could finish it up, but it is taking a bit more time than expected. No problem in that. We'll discuss in the next class. Keep watching. I know you must be like worried about the anatomy one sorts. Of course, I can. It will take time. Okay? It will take time. I'm just telling you that it will take time to record the lecture of your anatomy, because it's a job like I have to read myself also. Okay, then I can also teach you. Okay, because I'm not some expert or a jack of all trades, so I can just teach you pharmacology. We'll finish up this glaucoma, then we'll discuss the future course of action. I hope you guys are enjoying, and in DMs and in comments, I'm getting many messages that please do this part, physiology, anatomy, many things. But do understand, I have many things to do as well, many commitments as well. So I hope you will understand and keep reading. And in case of doubts, you can just reach to me at okay. This is my Insta ID. You can just text me there. If you can DM me there for in case of any doubts. And if you're enjoying, do like, share, and subscribe to my channel. Okay. So that's all in today's lecture. I hope you'll have a great day ahead. Thank you. Bye bye.